Good morning, everyone. Welcome to our webinar on Level 4 Reverification today. I'd like to introduce myself. I'm Margot McComas, your Trauma Nurse Coordinator. And with me here today is Diane Williams, our Trauma Program Manager.
Hi.
Okay, we're holding this webinar today in order to educate you, our Level 4 partners, on the new administrative rules and reverification criteria that have been put into Iowa Administrative Code. These new rules will help guide our trauma system moving forward. Today's schedule has 2 hours set aside for the webinar. We're going to start with a run-through of the new criteria and then a brief overview of the reverification process. And then there will be time set aside at the end of the webinar for questions, so be sure to write down any questions you have during the presentation.
And again, the plan is to do the questions at the end, and then they'll go in through the question and answer box or the
chat feature.
The chat feature. That way we can reduce the background noise during the presentation. So everyone's been muted. And do please be aware that this webinar is being recorded and will be posted. So if you do have any concerns with it being recorded, you can drop off the webinar at this time.
Okay, so Diane's going to give us some context about the rule change and what's been going on to get to this point.
Right, so it's been a long path to get to here. As you're all aware, we had the American College of Surgeons consultation visit that occurred in February of 2015. And one of the results of that was a recommendation that the department and our partners, i.e. all of you and our Trauma System Advisory Council, look at our administrative rules and the criteria that we have been using for verification. The committee felt that our verification criteria were significantly out of date and recommended that we would update those criteria. So in about July of 2015, a verification subcommittee, which is a subcommittee of the Trauma System Advisory Council, came together to review all of the criteria that we currently had and compare that to the criteria coming out of the American College of Surgeons, the Resources for Optimal Care of the Injured Patient, the 2014 guidance, which is commonly referred to as the Orange Book. So as part of that, the verification committee also started to look at the verification process, making sure that we're following the best processes available. I believe many of you are Level 4 facilities have engaged in the on-site verification of Level 4 facilities. That was a recommendation of the verification subcommittee. So you can see how this has evolved over time. The verification subcommittee also looked at the disciplinary process and wanted to make that more transparent for folks, helping them understand ramifications for not meeting their criteria, and helping them scale the criteria so that they can understand what priorities they should put forward first. So after much review, about a year's worth of work and working with varied levels of hospitals, all levels of the hospitals were engaged in this verification subcommittee. They made recommendations to TSAC that eventually resulted in updates to Chapter 134, the administrative rules called Trauma Care Facility Categorization and Verification, as well as updates to Chapter 137, Trauma Education. Those rules were all vetted significantly with the Trauma System Advisory Council, basically throughout all of 2016 and into early 2017. We also worked with outside partners like the Iowa Hospital Association and some other associations to ensure that these rules were a good fit for all of our hospitals, and then would give us the optimal care in our state. So the rules were approved by the Trauma System Advisory Council in January of 2017. Then they were processed, they began the administrative rule process in May of 2017, and having gone through 2 rounds of review by the State Board of Health and 2 rounds of review by the Administrative Rules Review Committee, a legislative committee, they became effective on September 6th. And in order to help all of our hospitals transition to these new rules, we're hosting this webinar, and then we'll be hosting a Level 3 webinar later in the month to really walk you through each of the criteria to understand what what the expectations are of these rule changes and how you can meet the requirements that are laid out there. We will say that overall, the burden for our level 4 facilities is reduced with these new rules. But like I said, we'll go through, or Margot will go through each of them and help you understand how it compares, what the new rules say, and what the expectations are. And again, what resources are available to you to help you meet those criteria. So at this point, I will turn it over to Margot, and she will begin a review of the verification criteria.
Okay, so we've got our criteria here. So our new criteria are going to be based off of, just like Diane mentioned, the Resources for the Optimal Care of the Injured Patient 2014, which was published by the American College of Surgeons Committee on Trauma. The book is separated into chapters, and each chapter contains criteria which may be pertinent to level 4 facilities. I think the important thing to keep in mind here is that not all criteria apply to you as a level 4, so you need to distinguish which criteria apply and which do not. And chapter 23 helps you do that. It's got a criteria quick reference, which will guide you on what criteria apply to your facility. Okay, so let's start looking into the Orange Book. We'll start with chapter 1, Regional Trauma Systems, Optimal Elements, Integration, and Assessment. So these criteria outline participation in service area, state, regional, or national committees and organizations designed to promote evidence-based, high-quality trauma care. What the verification team will be looking for to satisfy these criteria is a table of organization, both facility and trauma-specific, engagement in TSAC or with your healthcare network. Service area champions may be working with Danny Dowd's reports for service area performance improvement, and participation in Iowa coordinators through the Iowa Hospital Association. All those things could satisfy this criteria. You do not have to have all of them, but at least participation in some. Okay, chapter 2 is a description of trauma centers and their roles in a trauma system. Your relevant criteria are up top there. This chapter establishes a description of trauma center levels and the roles of each level in a trauma system. It establishes requirements for level 4 verification and what must be present at the trauma care facility to care for trauma patients. There must be a PIPS program. There must be a trauma peer review committee. There must be transfer plans and guidelines. And then what type of education must be present in the trauma team leaders. It also establishes the need to educate across the continuum of care, starting with pre-hospital providers. All centers must also participate in regional disaster management plans and exercises. So this chapter is really concentrated on the trauma program as a whole, how it identifies issues, how it educates its providers, what it has available, and how it interacts with its partners to improve care on a system level. So evidence that will satisfy these criteria, which the verification team will be looking for, is an establishment of a performance improvement and patient safety or PIPS committee with meeting minutes and attendance, an audit form for that PIPS committee, good tracking of loop closure, peer review with delineation of time for trauma-specific actions. We'll be looking at call schedules and how Danny's reports are integrated into the PIPS process, and also transfer protocols, which outline criteria for which type of patients the hospital keeps versus which ones it transfers out. Treatment and transfer guidelines, including burn and spinal cord injury management. We'll be looking at ATLS for providers who, and this is an important distinction here, are not boarded in emergency medicine or general surgeons. Those two groups, emergency medicine and general surgeons, must only have taken the course once. We'll be looking at education provided to pre-hospital and hospital-based providers, participation in service area or healthcare coalition disaster management plans and exercises. And I think it's important to note here that your hospital is doing this already. It's a requirement of CMS, these disaster management plans and exercises. So it should be pretty easy to tag into that if you're not the person yourself that does that already. So I also would like to draw particular attention to criterion 2.8. And this criteria says that advanced practitioners can be the trauma team leader and do not have to have a physician backup. So that one's pretty important, may alleviate some staffing issues at your facility. Okay, Chapter 3, Pre-Hospital Trauma Care. There's your relevant criteria up top there. And your trauma care facility just must participate in training of pre-hospital personnel. Your pre-hospital protocols, they must be on file, or an awareness of their location is important. Many of them may be online. And then ideally, your trauma medical director should be involved with the EMS medical director to establish collaboration on protocols. We'll be looking at bypass protocols, and that bypass and diversions are logged and sent through the PIPS process to assure they were appropriate and protocols were followed. Chapter 4 is interhospital transfer. A lot of this one isn't really new. Your relevant criteria are 4.1 and 4.3. Direct physician-to-physician contact for transferring patients is essential. And what may be just a little bit different is that the PIPS program should evaluate transport activities and review all transfers. So something like this might look like, how long is it taking for the decision to transfer? How long is it taking to get a receiving physician? How long does it take for the transport team to come to transport your patient? And how quickly is the patient getting to definitive care? Danny's reports that he is sending out, insert some of these indicators into your, or Danny's reports that he is sending out, track some of these things for you. And you could insert some of these indicators into your trauma charting and trauma audit to help you identify if there are system or provider issues and provide loop closure where appropriate. For evaluation of transport activities, it would be important to get a transfer follow-up communication from your receiving facility. This will evaluate the safety of the transfer, any issues that manifested during the transport. So for example, did the patient decompensate during transfer and require intubation? Maybe was there an injury that was missed before transport? Okay, Chapter 5 is your hospital organization and the trauma program. So just as in our previous criteria, there must be a commitment or resolution from the hospital administration, medical staff, and governing body. There must be trauma activation criteria. And the activation policy with specified activation criteria is laid out in the Orange Book. They have specific criteria that have to be present. There should be tracking of trauma team arrival time within 30 minutes. These are also included on Danny's reports. And other criteria specified in the trauma team activation protocol outside of what is required in the Orange Book should be evaluated by the trauma PIPS program to determine their necessity. So this may be a tracking of over and under triage. So for example, was a trauma alert not activated and should have been, or was a trauma alert called and didn't necessarily have to be called? And there is a formula available in the Orange Book for these calculations, and Danny and I will be working together to see if we can work this into a report from the state for you. And that may be hospital-based, because we would need some extra numbers that aren't necessarily in the registry. Chapter 6 are the clinical functions of general surgery. So this may or may not apply to you as a level 4. But there must be tracking of acceptable response time for general surgeons. An 80% attendance threshold must be met for 30 minutes post-patient arrival to the trauma bay. And this is tracked in Image Trend and distributed by Danny on a quarterly basis at this point. Okay, so that was chapter 6. Now we get to skip all the way down to chapter 11. So it's important to note there in the chapters between 6 and 11 that, just to repeat this, the surgeons and emergency medicine boarded physicians only need to have completed ATLS at least once, and they do not need to be current. All other physicians on the trauma team should be current in ATLS, along with your trauma medical director. Okay, so chapter 11, collaborative clinical services. This chapter brings in radiology, lab, blood bank policy for massive transfusion protocol, and guidelines for advanced practitioners. These criteria will mostly be satisfied on the SACA or the application that you fill out for your reverification, with the exception of the advanced practitioners ATLS and a credentialing policy for the advanced practitioners. So just a quick note about blood type and cross-matching availability. This will be interpreted by the verification team as the hospital being able to provide blood transfusion services, with the understanding that the blood bank itself may not be on site. I also want you to take a look at that annual review of the advanced practitioners by the trauma medical director. This would be included in the credentialing policy for your advanced practitioners. So chapter 13 is rural trauma care. And the criteria relevant in this chapter to level 4 facilities, as you can see, are pulled from a couple of different chapters here. But some of them are from upcoming chapters, so I just want to take a quick look at those. 15.1 discusses the maintenance of the trauma registry, which is accomplished through data entry and image trend and tracked through Danny's reports. And 16.10 will be evaluated based on the PIPS program and the plan to identify system level issues. This would include taking a look at the PIPS audit form and a clearly defined plan for event identification. Okay. Chapter 14, guidelines for the operation of burn centers. And this one is pretty straightforward. Trauma centers that refer burn patients to a designated burn centers must have in place written transfer agreements with the referral burn center. Chapter 15, the trauma registry. Okay, so in this chapter, we must have a designated person who enters registry data regularly. Registry data must be used in the PIPS process, whether from Danny or a hospital-generated report. The registry should drive prevention efforts. So, for instance, have there been an uptick in falls at your facility, injuries where safety equipment should have been used and wasn't used, any workplace-related accidents picking up, and how are you basing your outreach off of an increase in any of these areas? Trauma registry should be up to date, where 80% of the incidents should be entered within 60 days of discharge. And for data validity monitoring, this can consist of an internal hospital policy to manage data and patient identifiers. Data validity should be monitored by the program, so making sure your program identifies all the incidents that should be entered, and including this monitoring in the performance improvement process so that adjustments can be made to make sure all injuries are being captured. Okay, so chapter 16, this is probably our biggest chapter that I just want to kind of note that this chapter is pretty complex and highly important, so it should be reviewed by you and your trauma medical director in your facility pretty extensively. So the new Chapter 16 criteria are those up top there, 16.5, 8, 10, and 11. So 16.5 is a big change from the previous criteria. The trauma care facility must have a written PIPS plan that includes all processes and outcome measures used by the PIPS program. The written plan must be updated annually. So every year you'll want to revisit your outcome measures and see if those outcomes were something that maybe were met 100% of the time. So do you still need to measure those or watch them, or can you move on to something new? The best part of this, though, is that there's a suggested outcome measures box in Chapter 16. So they give you an idea of maybe where to start if you don't track anything outside of your regular measures. In Chapter 16, you must also track transfers to a higher level of care within your facility. And this may apply to you or not, but say you, for example, you admit somebody to the med-surg floor, and then they need to go to ICU. This should be monitored and taken through the PIPS process in order to see if there were any opportunities for improvement. Just a patient example, maybe there's somebody that smokes 2 packs a day with rib fractures and a broken sternum on a couple liters oxygen. That patient may get admitted to med-surg and then develops respiratory distress overnight and ends up transferring to the ICU for airway controller to go on BiPAP. So maybe were there any interventions that could have been addressed earlier, any changes in pain control, maybe coughing and deep breathing using his incentive spirometer that should have been put in place before this patient had to go to the ICU. So that's an example of looking at your transfer and were there any opportunities for improvement. 1610 addresses a mechanism for event identification, and 1611 can be included in the PIPS plan. So if a patient has a complaint about treatment, how do you validate the information that they tell you? Do you look at chart review? Do you do provider interviews, etc.? Okay, so I realize that there's a lot of information for this chapter, and I'm going to break it down just a little bit more. And with the knowledge that some of you may be very familiar with this, while others maybe this would be brand new information. So please just bear with me while I look a little bit deeper into the PIPS processes and definition. So the PIPS written plan should describe the process for monitoring and measuring the outcomes of trauma care at the facility in order to improve efficiency, increase effectiveness, reduce real or potential harm, and improve future outcomes. So it must include the core outcome measures of trauma surgeon response time to the emergency department, trauma team activation criteria, and there I have listed the page where the minimum criteria are listed in the Orange Book on page 120. It must include acute transfers out, noting the rationale for transfer, appropriateness of care, and opportunities for improvement. And your PIPS plan must track transfers to a higher level of care within the institution, just like we talked about on the previous slide. It should also identify the participants in the PIPS process, so who is included in your PIPS meetings, as well as what will constitute each level of review. So for example, what does a primary review look like at your facility? What does the secondary review look like, etc.? So we'll kind of go into those just a little bit here. A brief overview of the levels of review. These are also outlined in Chapter 16 for your reference. So a primary review is the identification and validation of the event. So this could be done by the trauma program manager or a designee. And this may be, the issue may be able to be resolved at this point. So maybe immediate feedback to the provider or nurse. A secondary review is when the identified event requires further investigation and who it gets passed on for another look. This could be passed on to your trauma medical director then. This secondary review includes a review of the medical record, a confirmation of individuals involved in the care, a development of the timeline of the event, a review of any other pertinent documentation, maybe an autopsy report. And then, once again, you may have immediate feedback and resolution at this point. And then you've got your tertiary review there, your multidisciplinary review, with the goals of reviewing the efficacy, efficiency, and safety of the care provided, providing focused education, or providing peer review. There is a quaternary review, and this is done by the hospital quality committee or by external peer review. And this may be an examination of extraordinary cases or just to validate your process. Maybe you have the quality committee look at what your process for a certain patient and was your response to that certain patient's situation appropriate. Okay, so event resolution or closing the loop. Here we can use an example, I think, that's pretty good. So maybe you had a death at your facility, which was found to have an undiagnosed tension pneumothorax. Maybe the provider didn't obtain a chest x-ray upon patient presentation. You did loop closure with the providers on standard order radiology tests on your high-level traumas to include a chest x-ray. Then you can monitor your compliance with that order set for the next quarter to ensure the teaching was effective. Or if you're still having issues with chest x-rays getting ordered on high-level traumas, then maybe there needs to be some more education surrounding that issue. I think the important thing to remember for the verification team is we'll just want to see some documentation around this loop closure, how you were educating your providers and what you did to close the loop on that situation. Okay, so I've included this graphic from the Orange Book because I like it. I think it gives a good visualization to the process, but I hope it doesn't complicate things too much for you. So this is just a visual representation of the levels of review, and something that I particularly like is the actions piece to this graphic. So as a result of the review process, what was the action taken? And then as a result of that action, did you then review the outcome and monitor for optimization? Okay, how can the state help? So we've got some education coming up here. We are offering our Rural Trauma Outcomes Performance Improvement course, or TOPIC. That's being offered on September 26th and 27th. You should have received information about registration for that class, so if you have not, please contact me via email. We're also in the process of developing a registry training course for data collection and input. Danny and I can offer your facility technical assistance. So this is where we come to you and talk about the criteria and the registry, look at policies and procedures, give any suggestions on how to move your trauma facility forward. Danny also offers assistance through a webinar where he utilizes screen sharing and provides assistance on registry issues. And then we can share with permission documents and policies from other facilities in Iowa that can be used as templates for you. And last of all, we have data. So Danny can help you set up your registry to assist you in the PIPS process, help you run reports, and tailor your data to your facility. Okay, so that's chapter 16, kind of a big chapter.
Before you move on, I think there was a couple questions that came only to you, and I couldn't see them.
Okay.
So I don't know.
Will the slides be sent out for the webinar? Oh.
Oh, maybe not. Maybe there's no other ones. Okay.
Okay, so we've got Chapter 17, Outreach and Education. Okay, so all verified trauma centers must engage in public and professional education. So for the verification team, this is just going to be a list of education provided to pre-hospital, hospital, and then the community at large. All right, Chapter 18 is prevention. Okay, so there must be an organized approach to injury prevention, and this just means looking at your registry, community trends, maybe public health initiatives in your area, and tagging onto or supplementing those efforts. Injury prevention language should be added to the job description of either the trauma medical director or trauma program manager, or your facility may be lucky enough to have a separate person who takes care of this injury prevention effort. But if not, it should be documented, it should be added to the job description of either the trauma program manager or trauma medical director. There should be universal screening for alcohol, and that must be performed on all injured patients. So, and I do want to emphasize here that this is screening and not measured. So we will just want to look at a policy that shows a process for alcohol screening for injured patients. Okay, we're getting closer. Chapter 20 is disaster planning and management. So this one is going to be new to trauma verification, but it may not be new to your facility. So this provides you with a great opportunity to tag into your service area activities, as emergency preparedness is part of the requirements in those areas. We'll also be looking at a hospital disaster plan and disaster drills. And just for your reference, I have here a visualization of your service area, so you can pick out which service area you are in, and you can contact me for the contact information of your preparedness coordinator to get you involved in those service areas. Okay. Chapter 21, solid organ procurement activities, and this is your last chapter. So there must be a written protocol defining the criteria and confirmatory tests for the diagnosis of brain death in your facility, and this will just be asked for as part of your application. All right, so we've gotten through the criteria. So I'm sure everybody has questions now, but we will address these at the end of the webinar, and we'll move into a brief discussion of the reverification process at this point. Okay, a timeline for reverification. So 6 months before your verification certificate expiration, you'll be getting an email from me that says, hey, 6 months from now, your reverification is due, and I will include on that email your application and the materials needed to be returned to me. I'm asking for those materials 4 months before your certificate expiration date. So that will just give me enough time to review the materials, talk with you if we need anything back that may have been missed in the application, and then it will give us time to set up a paper or an on-site review. If you choose to opt into the on-site review, we try to conduct those up to 1 month before your verification certificate expiration date. So if your certificate runs through December of 2017, we would want to get your on-site review done sometime in the month of November. And then after your on-site review or your paper review, you should receive a final report within 30 days. This is the process that the verification team has looked out for criterion deficiencies. So your packets that you received from me before the webinar included a checklist with the criteria. And these criteria were listed as either type 1, type 2, or type 2B. So type 1 criteria, as you can see, are a little bit weighted, weighted a little bit heavier. Type 1 would then be a notice to the CEO and board of directors with asking for a plan of correction in 45 days. And then we would perform a focused site visit 3 months after that plan of correction. Okay, so type 2 then would just be a paper report in 6 to 12 months for me. Maybe you didn't have a policy for the clinical criteria to confirm brain death, so you guys put that together and get that to me a year after our visit. And type 2B deficiencies then are just a focused site visit in 6 to 12 months, something that maybe can't be put down on paper, like a new PIPS process put into place, etc. So this is just a general plotted map to help understand the process, and then if not verified, the department would then take additional regulatory action. The final report that you receive details the strengths of the program, any criteria deficiencies, what level they would be, and if it was a level 2 or a level 1, what materials would need to be returned to me and when. And then any recommendations to move the program forward during the verification period. Okay, so this is the part where you can start asking me some questions on the chat. I appreciate you guys listening in.
Okay, Margot, so there have been a few questions. Will the slides be sent out after the webinar? And yes, we can accommodate that. Who do you consider as advanced practitioners? So these would be your nurse practitioners and your PAs that are working primarily in your EDs. Those are who those folks are. Okay, so this is a question for you. Is there a benefit to either on-site or a paper review, and how does the paper review work, and which is recommended?
Okay, so I personally, having experienced both of them now, I personally like the on-site reviews more than the paper reviews. Paper, you can only get so much information about a facility, how that facility functions in the trauma system as a whole, and what I can do in my job a little bit better to help move that facility forward in the future. The on-site reviews bring trauma experts from the state to your facility. It's a great learning experience on both sides. Your facility educates us on how you care for your patients, your trauma patients, and then the on-site review team in turn can educate you on any new trauma
Practices?
Yeah, practices going forward. Thank you. We also, as a verification team, then learn how you fit into the trauma system and what we can do better on the state level to help your facility in any way that we can.
And Dr. Thomas did chime in on the chat that on-site visits are very helpful and consultative, and I would agree with that. That's the feedback we've primarily received from all the hospitals that have on-site reviews done. Like I said, it seems a little scary at first, but they have found much benefit in it. So the next question is, where can we get a copy of the new Orange Book? And that's fairly easily accomplished through Google. Just Google American College of Surgeons and Orange Book, and it'll take you right to their webpage, or just go to the ACS webpage. We have also posted it on the IDPH webpage. It's under BETS for the Bureau of Emergency and Trauma Services, under the Trauma tab, and then under the verification resources, I believe, under verification. So either one of those places. The next question is about alcohol screening versus alcohol measurement. So what is considered alcohol screening? Does every patient have to have a lab draw, including pediatric? So,
and this is where I had confusion in the past. And to me, I was reading screening and thinking that there needed to be a number to go with that criteria. And the answer is no, there doesn't need to be a blood draw or a number associated with that criteria. This would just be a screening that you would do, I think essentially with any patient that I've had in the hospital setting, what are their social habits? And alcohol is one that needs to be covered. So that would be us looking at a protocol or a policy for you that says you screen 100% of your trauma patients for alcohol use and abuse.
agreed. So the next question is there a grace period for a provider to obtain ATLS on hire for the ER? I might actually have to table that question, or do you know the answer?
I would say that in the Orange Book, they are pretty clear about having current ATLS. I would also have to look at that a little bit further because I do think that there is a little bit of trouble with getting into a class at this point right now too. So we would just probably have to look at that.
Right. So new grads should have that without trouble because they would have had that before they graduated. It's if you brought new ED physicians in from out of state, that may be a challenge for you. We've worked over the last 3 to 4 years very heavily with all of the, for lack of better terminology, the rent-a-doc groups, and they understand that physicians that come into the state to work in our EDs have to have ATLS. So we can see for sure, but it would have to be an extremely special circumstance. So if you do have that circumstance, please send us an email and we can look into that with you. But we'll just generally look into that. But it would be a very limited case that would be allowed. Okay. So regarding the written protocol for diagnosis of brain death, we wouldn't have any diagnostics to determine brain death. Do we still need a policy? Yes, because yes. So I don't know exactly what you mean by diagnostics. You'd be able to do a patient evaluation. And I think this is an area that we could work with TSAC to be able to provide recommendations. We can also look at some of the other facilities, hospitals that do have policies and what it is that they're setting forth as criteria for brain death. I think those would be good resources, and we're happy to work with TSAC and our other partners to identify best practices or recommendations. But yes, a policy of some form is going to be required, right? Mm-hmm. Yes? Okay, she's nodding.
Mm-hmm. Yes. I agree.
So where can I get the Orange Book to review? Again, you can get it on the ACS website, or you can get it through the IDPH website under bets and trauma and looking at verification materials. So please explain how detailed is the participation in hospital training and review of protocols. Are we talking about, so EMS, looking at how much EMS training you're doing and how much review you're doing of their protocols?
I think that's probably what they're saying there.
Okay. Do you want that one?
So for pre-hospital training, I would say some things that I can think of off the top of my head would be the Rural Trauma Team Development course, having done that and including pre-hospital folks in that. Doing any ATLS, BLS training, anything to do with transport processes and looking at those with them and seeing if there's any education that can be done on both sides. Review of the protocols. Do you have them on file? Have you had a problem with somebody coming into the hospital, maybe that you thought pre-hospital care wasn't optimal, and so were you able to look at that protocol and see that maybe their protocol wasn't up to date, so then you gave some recommendations on updating a protocol? through your trauma medical director, things of that nature. But, just having them on file or knowing where to get to them, and just maybe doing some review of them through the PIPS process would be appropriate.
And I think this is one that we're going to look at as a stretch goal. I mean, we're going to initially look at, what interaction are you having with your EMS folks, but we're going to want to see more engagement and documentation of collaboration so that you are really optimally caring for these patients. Are they doing everything that you as a hospital want them to be doing for your trauma patients to ensure the best possible care? So yeah, okay, let's see, what was the next one? Do PAs and NPs that always work side by side with an ED physician need ATLS? So the ATLS requirement is for those that would lead a trauma resuscitation. So if you ever have NPs or PAs that work in your ED without a physician, they would need it, correct?
Yes, that's how I would interpret that.
So if
they're taking night call without a physician backup, then they would be required to be current in their ATLS.
If a physician's not current with emergency or surgery boards, they have to be current in ATLS, correct?
Yes, I do believe so. I would have to look at to know specifically, but if they are not up to date in their boards, then they should be current in ATLS.
So the Iowa Donor Network liaison should have criteria as well. Oh, for brain death declarations such as apnea tests and others. Excellent. Thanks, Beth. Any patients with signs of life would be transferred out of our facility. We would never diagnose brain death at our facility. I think this would be common at level 4 hospitals. What would the policy include? Maybe it's as simple as all patients will be transferred out. And then if looking at the Iowa Donor Network criteria to confirm death would be maybe appropriate as well. It doesn't have to be a giant, elaborate protocol.
Right.
But, short and sweet to the point is just fine.
Yeah, absolutely.
Okay. Do you have a contact for RTDC? I have emailed the contact on our site without response. Anna, if you email to Margot, we'll get you connected. And I do want to remind everybody on the webinar that we still do have those RTTDC manuals available, and we'll work with the sites to see if we can get stuff set up for you. So Linda, again, would you email Margot and we'll see if we can help with some of the sites to see if we can get you some training for RTDC. Are there any other questions? Oh, a few more. Okay. Please clarify, the criteria states that all non-physician medical providers are to be current with ATLS. So that would be your
advanced practitioners,
your PAs, your nurse practitioners. And then can you share examples of policies that are required for reference for the group? Natalie, I think if you email Margot and just let her know what you're looking for, she's gotten policies from different folks from across the state, correct?
Yes, that have okayed me to share them.
Yep, so she can hook you up there. Is there a way that we could look at the application prior to the 6 months so that we make sure that we have everything ready ahead of time? We love to hear that. Yes, Stacey, you may. On the IDPH website, again, under BETS and under trauma, under verification, that's where you'll locate the SACAs, and you are welcome to look at them anytime you want. Along with the criteria, please continue to look at that criteria throughout your 3-year time period. Don't just look at it when you have to get ready. That's not the ideal. We want you to be looking at and using these materials all the time. If you have any trouble locating them, again, I will offer you Margot, and she will help you. And the guide, it looks like the advanced nurse practitioners and PI are to be current regardless of physician's presence.
Yes, that's correct. Oh.
I think page 11 of the.
I think she might be referencing what we said about what Sherry's questions were.
Okay. Are there links that can take us directly to these items? I found it difficult to maneuver the IDPH website. Yeah, we can send those out. I don't have a problem doing that. Yeah, or Margot. Has the application been updated to include these changes? So Margot, she's looking up on page 11, but Margot has been working with the verification team to update the level 4 and level 3 SACAs. I believe the level 4 SACA is very close and will be posted within the next week, and the level 3 is under development. So yes, the SACAs will be updated to these changes. The next question is, could you provide the examples for criterion deficiency types? So I believe you did, correct? It's that document that had listed out all of the criteria, the level 4 criteria. There is a column that identifies type, and it'll have it typed as 1, 2, or 2B, correct?
That's correct. Mm-hmm.
So that document, if you have any difficulty locating it, just give us an email or a shout, and we will take a look.
And I apologize, that page 11 in the 2014 version of the Orange Book does not include anything about the...
I wonder if it's page 11 of the document that you sent that has the criteria. You might have to give us a little additional reference on the page 11 so we can just make sure we're looking at what you're looking at. And Dr. Thomas is writing that we really encourage trauma order sets that include alcohol tests. The lab can be deleted if not appropriate. It is surprising how many falls are alcohol or drug related, even in our elderly. Apparently there's been some surprise finds that our elderly are maybe having more falls and there's some alcohol involved, or drug related medication issues. She was doing the criteria document. I don't think we have that one handy.
I don't have it handy here. I could look it up, but I don't.
We'll get back to you on that, but yes, we agree. Really, if you have a PA that does work with your trauma care facility, a PA or a nurse practitioner, they need to have ATLS.
That then they would be the trauma team leader, that they're taking call by themselves.
Oh, and there was a comment about alcohol dependency in our elderly population. Okay, folks, we're happy to answer any additional questions. I think we're done fairly early here. You don't have any additional materials to provide, do you?
I do not have anything additionally. Q&A portion be included when slides are emailed out for future reference. So I did email the slides. Alicia, I will email you personally because the slides were sent out beforehand. I sent them to all the trauma program managers, so I will look at getting you a copy. But this webinar is being recorded, so you will be able to access the question and answer portion at any point in time.
And just one more plug for the rule topic class that we're hosting on September 26th and 27th. Again, we're offering the session 3 times, so you wouldn't have to come both days. It's from 1 to 5 on September 26th. It is from 8 to noon on the 27th. And again, it is from 1 to 5 on the 27th. Those classes are being hosted in Ankeny. Our speaker is Jory Klein. She is the trauma medical director at Parkland in Texas, Dallas, Texas, which is obviously a giant facility, but she has gone out all across Texas talking to small facilities and helping them develop PIPS programs that are realistic and achievable for their sizes of institutions. And so at this training, she's going to bring resources and documents to share with all of you that you can use to develop PIPS programs that are really tailored to the level 4 sized facility. So we genuinely hope that you can make that training. If you can't, please try to send someone else. We also welcome you to engage in your other partners. So if you have EMS partners or other community partners, this is a general performance improvement course. And so while it's specific to topic, it will be very useful to you and your partners as you work on system development activities. So will we have time to get to Ankeny after the Iowa Trauma Coordinators meeting? My understanding is yes, we've tried to schedule it that way so that you could go from the Iowa Trauma Coordinators meeting in the morning to Ankeny in the afternoon, and we'll work to accommodate that. Anything else?
I don't think so. I really appreciate everybody joining us today. Again, if you have any further questions, please just email me, and I'll get you the information that you need.
Thank you all so much for joining us. Have a great day.